We'll move to the next presentation by Dr. Rajul, who is the director of Shreeji Eye Institute and Research Center and Palak Glaucoma Care. Vast experience in glaucoma, almost 60 publications in peer-reviewed journals, 17 book chapters. He has been the society editor of IGR, the member education committee of World Glaucoma Association, and also the chief editor of the first guidelines of the Glaucoma Society of India. He'll be speaking on MIGS in Indian perspective.
Thanks, Manish. So I'll be talking about MIGS, what's the future from the Indian perspective. This talk was made by Dr. Shefali. I've just changed first slide and I've written the whole presentation as it is. So the currently, as everybody talks about it, that it is like a sandwich therapy between medical treatment and the full-fledged surgery, in between MIGS. And there are lots of MIGS is basically a combination of multiple different surgeries based on a different pathway. So it can be on the Scams canal, on the suprachoroid, destructive procedure. Initially, conjunctiva was not part of the MIGS. After the incorporation of Zen, the conjunctival also has been classified as a MIGS, the subconjunctival filtration. So what we have is Zen is still not available, Bang, GAT, mainly the things which works on the Scams canal. So the skill required, the gonioscopy. Gonioscopy is the most important aspect of course, glaucoma management per se, but if you don't know gonioscopy, then it's very difficult to do the mixed surgeries, because the surgical gonioscopy, you have to know, is a direct visualization. I'm not going to talk much about it. The patient selection, so of course, the initially nowadays what most of the people say that early to moderate glaucoma patient on 3 medications, primary, if the patient is angle closure, especially with synechiae, then you should avoid. Secondary glaucoma, at this point in time, no. The instrumentation, of course, there are different kind of the surgical gonioscope. You have a hands-free gonioscope, which we routinely use in our surgery, and you have the regular with the handle, which you have to hold it. So whichever you are comfortable. The docking of gonioles is very important. So these all things are the basics. If you want to do the mix, then you have to know how to do gonioscopy, how to dock the lens. Since we have only 10 minutes, I'm not going to talk much about it. The positioning, the tilt at 35 degree in the microscope and the patient position exactly opposite as far as possible. It should be tilted on the opposite side of the eye. So those things are very important. Then there are 3-4 small surgeries I'll show you before we shift to the evidence, efficacy and Indian perspective. So this is Bang, the de-roofing the Scams canal. You can see, cut it, the Scams canal, the over it, PTM. This is KDB. KDB is de-roof much better way than the Bang. Is much more, I would say, the same thing, but in a much better way. But the blade is more expensive. It costs 30,000 rupees per blade, and you can use 2 to 3 times max. This is Ganesh. Ganesh does lots of GAT, so I borrowed his video. So you take a 60 Prolene and pass through 360 degree from the canal and de-roof the canal. This is one of the surgery where you de-roof the Scams canal 360 degree, and in MIGS, one of the most difficult surgery to master, because it requires much more skill, and the risk of hypema also is maximum with the GAT. The Bang, the eye stand, I had few, but since Amit does too many eye stand, he had much better video, so I have borrowed from the Amit Pandey. Very easy surgery to perform. In fact, injector, you go, identify and just inject. You have to be careful because there are 2 eye stand, so you have to be careful, and second you can go and inject on the separate side. So these are the few which is most commonly available in India. So my experience, so as I was very reluctant starting mix in our center. The Shefali convinced, and what she was talking about was this patient nearly 3 years ago when we started doing the mix. 49-year-old patient, we are following him up from 2009 or 8. We did 2007 first trap, then Express, then AGV, then FICO, then second AGV. One-eyed, maximum medical treatment, advanced glaucoma, on Dimox, acetazolamide pressures were going up to 25, and that is the time we were thinking what next now. So we had, of course, the destructive process is always an option, but the risk of vision loss is always there with destructive procedure. So that was out of the box. We thought that if we can do bank and if it works, we can avoid the destructive procedure for some time. So this was the first, one of the first MIGS procedure we did, and this is now more than 2.5 years. Is on maximum medical treatment. All drops are still on, but without acetazolamide, his pressures are fluctuating between 12 to 15. Has not progressed for 3 years. So this was the case when we started doing the MIGS on a more routine basis. And this is a second, other extreme I am showing. This is what most of the people say that MIGS should be done. 45-year, 2 to 3 medication, was on intolerant on other medication, 0.8 inferior notch, other eye was inferior thin. He was reluctant for traps. I still counseled for the trap only, but he was reluctant. He had gone somewhere and had come with the MIGS. We did MIGS, it failed in 8 months only, and we had to do the trap. But otherwise, this is considered one of the ideal surgery, early moderate glaucoma, only on 3 medication. So from then, this is our experience. We are doing as primary surgery combined with phaco, and as last resort, before doing destructive procedure, as we both are not very comfortable doing destructive procedure as far as possible in a seeing eye. So this is a primary surgery, phaco. The phaco IOP reduction is maximum, but you have to understand that it is because of the cataract surgery also, and the cataract surgery, if it goes down over a period of the years, so our follow-up is still limited. The mean follow-up is 1 year to 15 months, 12 to 15 months. So this is too small period when you talk about glaucoma management. The complications are very limited. Hyphema is one of the most common complications. They usually resolve. And one patient had a iridodialysis when I was doing the bang. Efficacy, now this is the most important aspect. When we want to talk that MIGS should replace the glaucoma surgery, trabeculectomy, then the most important aspect is not ease of doing. Most important aspect is that how effective the surgery is for a long term in relation to the standard surgery, which is trabeculectomy at this point in time. So this is bang. If you look the bang, the 20% IOP reduction in 70% of the patient, and this is only 6-month follow-up. You remember that? Only 6-month follow-up. So in 6 months, 70% had only 20%. As the duration of surgery will increase, the success will reduce. So this was eye stent comparison with phaco IOL. The 33% IOP reduction in MIGS with phaco and 29% in only phaco. So additional 4% IOP reduction if you combine the eye stent. Another 2% extra reduction. This is 4-year, 11% reduction with MIGS and 2% with phaco. So here one other important aspect which you should realize, that as the duration of follow-up increases, in only cataract surgery, the IOP percent reduction start going down, because the effect of IOP reduction with cataract surgery is very limited and the pressure goes back to the baseline. So that is important. So cataract should not be considered, because some of my patient comes in that cataract, doctor has told that cataract will reduce the pressure. Cataract reduces pressure only for limited time. So it is not a glaucoma surgery. So, but only 9% over a period of 4 years. Then Horizon study. Horizon study was first one of the big RCT, hydrous implant plus phaco versus phaco, and they found that the IOP reduction was little better with phaco plus hydrous, and progression was little less. The second was compare where hydrous versus eye stent, and they found that IOP reduction was significantly more in the hydrous, though hydrous is not available in the India, but it is much better than the eye stent. And IOP reduction, the drug reduction, both were much better in hydrous. So I am hoping that hydrous, if it comes in India, we will be able to analyze from Indian eye. And this is the most important for me when I do RCT, and the second is the meta-analysis of RCT. So these two gives the very clear-cut idea about the what evidence you have to use in your clinical practice. And this meta-analysis, I just put the abstract. If you look the conclusion talks about that the MIGS is better than phaco IOL. Now, when the author has to compare a surgery, glaucoma surgery with the cataract surgery, that itself shows that the surgery has a several limitation. So, MIGS has limitation that it can reduce IOP, but not to the level to the any other glaucoma surgery. And this is just the overall a table showing what four we have available in India is Bang, KDB, iStent and GAT. The GAT reduces IOP reduction little more than other, but the GAT is the most difficult surgery to learn and has a high chances of hypema. So the cost effective, all are cost effective. KDB is cost effective if you use only 2-3 after doing ETO. And long term data is not available. The maximum is 5 years with the iStent. So we need more long term data. So to conclude, when I talk about ideal glaucoma surgery, these are the 5 things I will look. Effective as trabeculectomy but safer. Reproducible, easy to perform, less postoperative and cost effective. Now if you look the mix, it is not effective as trabeculectomy. Reproducibility again, some are, some not, because GAT and all that is not reproducible, it's a very difficult. You may get away in first eye and the second, third, fourth, you may not able to pass 360 degree. You require much more technical expertise. Easy, yes, as I said again, Bang, KDB are easy to perform, iStent is easy to perform, GAT is difficult to perform. Post-operative effort, yes, less. Cost effective, yes. Once you remove iStent, most are cost effective. But the IOP reduction is very nominal compared to TRAP. So to conclude, angle surgery, of course they are gaining importance. I am not saying they are bad. May fill the gap. Still, I would go back to my first slide. It is a sandwich therapy. Gap between the medical and laser surgical treatment. But you need to know gonioscopy. You have to have long-term RCT data. And at this point in time, once you leave the Bang, the cost is an issue. So KDB is cheaper, but iStents are very expensive. So you have to choose your patient wisely. Cannot start doing mix in every patient left, right and center. Thank you.
Thank you, sir. I think Dr. Rajul will have to leave. So if you have any question for Rajul or any comments, Panjanda is doing a lot of mix. How has been your experience with mix?
So as we heard from Dr. Rajul that we were very sure that actually the excisional goniotomy showed a good response in a very refractive case in one
Sure, huh?
Yes. So when a surgical procedure is definitely showing result in refractive cases, so that surgical procedure is definitely going to be effective in treatment naive patients.
Yeah.
But it cannot be definitely compared with trabeculectomy.
Very definite.
Yes, I am. We
Not to
need to be very sure.
Not to replace the standard surgeries.
No. See, the thing is that MIGS is not going to replace trabeculectomy. That is for very sure. And the standard of treatment or whatever we want from the surgery, our aim is also different. When we are aiming for a intraocular pressure below 15 for a patient who is presenting with a pressure of 28, we cannot go for MIGS because we know that the average reduction is 18 to 20%. Some special patient can have can give an additional up to 30%. That is a rarity. Is one side of the curve, but its average is 20% reduction and one medication reduction over a long period. The long being, for me, it is 2 years. For you, it is probably 6 to 7 months. I do not know. But for me,
I would, in glaucoma management, I would not consider 2 years as long term.
Yeah,
Anything
definitely.
less than 5 years, I would say that it's...
Definitely. But if we look into one particular patient scenario where sometimes the patient is skeptical about a trabeculectomy procedure. Some patients are one-eyed. Some patients, so we should learn everything, and everything should be in our armamentarium so that we can try, because there will be a niche amount of patients where a thing should be possible. That is sure. And another thing is a group of moderate glaucomas, where, you know, definitely the patient should do well with 2 drops or 2 bottles and maybe a cataract surgery. The same patient may not be compliant in our cases because non-adherence is a big
issue.
thing. So the same patient, if we offer a minimum bang with a cataract surgery, and I have seen the bang results are not exactly very bad. Some results are pretty good. So if we can do it properly and perfectly, it gives good result, at least for 1.5 years. At least for those days, the nerves are saved. That's what I want to do. Like, why not offering something to a moderate glaucoma
So,
or a mild glaucoma when the patient is undergoing a cataract surgery?
early moderate glaucoma, if you're doing cataract and if you want combined with the MIGS, I think it's not a bad idea.
Yes.
But counseling patient properly that it is a short-term solution, not a very long-term
Yes,
solution.
definitely.
One question I have related to MIGS is that a lot of patients, they do very well with MIGS, some they don't respond that well. So any particular criteria pre-op you have seen on gonoscopy or clinically which you feel that these patients probably do better compared to anything you have seen? No. And if you have to take one choice, like the KDB now, the bang, GAT I think you just said is more traumatic, or the eye stent, and patient has given it to you, you decide whatever best you want to do. So what is your preferred choice
Among MIGS?
among MIGS?
So, if I have to choose between bang and KDP and cost is no issue, KDP would be little better because it cuts much smoothly exercise, where the bang cuts.
Much more precision.
So otherwise, eye stent is very expensive. So, but I don't mind if the patient is no issue because eye stent is much easier and no trauma to the angle at all whatsoever. So that way would be better. So, but you choose depending upon the patient. But yeah, bang or KDB in most of the patient because easy, less traumatic.
KDB is excisional.
KDB, excisional.
Another good point, like at least theoretically, if the patient is responding well to a ROCK inhibitor, he should do well to MIGS. At least theoretically. If the patient is doing good to a ROCK inhibitor, they should do better to an MIGS.
I didn't get you. What you said?
If the patient is getting a good reduction, if the intraocular pressure is getting reduced to a good extent by a ROCK inhibitor,
Okay.
usually these kind of patients, they should do well with MIGS, theoretically.
So you are extrapolating
We are
the
just
mechanism
trying
of
to extrapolate, but
Okay. But that's an interesting thought process, but I don't think we have any literature about it.
Anyway, thank you, Dr. Rajul. We'll move to the
What Dipanjinder said, that there are studies to support that drugs like ROCK inhibitors, the cases which respond to ROCK inhibitors probably respond better to MIGS.
Sure. Thank you, Dr. Rajul.